My poster is regarding severe barotrauma secondary to traumatic intubation resulting in compartment syndrome. Pulmonary barotrauma caused by mechanical ventilation is a serious lung injury. Most of the time, it's due to alveolar rupture that occur due to elevated transalveolar pressure. This can result in developing pneumothorax, pneumomediastinium, and/or subcutaneous emphysema. My patient was an 88 years old with past medical history of COPD who presented to the ED with a chief complaint of cough, wheezing, and shortness of breath. Patient was found to be hypoxemic and hypercapnic, for which decision was made to intubate the patient, place her on a mechanical ventilation, and transfer her to the ICU. After 3 hours in the ICU, patient passed a weaning trial. She was alert and oriented, and she was saturating 100% on non-rebreather mask. Patient, during a physical exam, was having a stridor with bilateral diminished breath sound over the basal. She also had mild wheezing and extensive subcutaneous crepitus over the anterior chest wall. Also, it was noticed on the neck and the eyelids. Decision was made to obtain a chest X-ray. Chest X-ray was ordered stat, which showed extensive subtissue air involving the lower neck and the thoracic wall and the pneumomediastinium, as we can see in figure 1. CT thorax was done, which it confirmed the same findings found on the X-ray. Decision was made to proceed with a CT neck, which showed the same findings as the CT thorax, with a questionable tracheal tear at the level of the right thyroid gland. Cardiothoracic surgery and ENT were consulted. Recommendations were to proceed with esophagram, which was normal, without evidence of contrast, extravasation. ENT recommended doing laryngoscopy or a bronchoscopy with a tracheostomy plan. However, patient's clinical condition worsened. She developed renal failure with a compartment syndrome with an intra-abdominal pressure of 27. Family were informed and decision was made to change code status and transferred patient to a hospice service, where she was terminally weaned and sadly expired shortly after transfer. Incidence of pulmonary barotrauma is very high, especially with a specific disease such as COPD, pneumocystitis pneumonia, asthma, and may predispose patient to have a pulmonary barotrauma when they are on positive pressure ventilation with higher settings. Auto-PEEP is one of the factors that leads to overdistension of the alveoli and increase the risk of having barotrauma. Close surveillance of the patient after extubation is very important to prevent barotrauma of the lungs. Also, good physical exam with a frequent palpate on the chest for crepitus and follow-up on X-ray are essential in high-risk patients. Thank you for listening and have a good day.